Start ACINO symposium. We have our great speaker, Professor Fathallah Sidqi, Professor of Hematology Gastroenterology, Alexandria University, will give us a lecture about pitfalls in GERD management. Go ahead, Professor Fathallah.
Thank you, Professor Yusri. I want to welcome you all, and thank you, and I give my thanks to ACINO company for sponsoring this symposium. And I want to apologize about my Egyptian English. Of course, it is a bad luck to speak after Professor Schreiber. My talk today will be about pitfalls in GERD management. I will quickly speak about the management of GERD, and then I will speak about some pitfalls. GERD is a condition which develops when the reflux of stomach contents causes troublesome symptoms and or complications. The troublesome symptoms are mild symptoms occurring 2 or more days per week, or moderate to severe symptoms occurring more than 1 day a week are often considered troublesome. GERD is diagnosed based on symptoms. It is a symptom-based diagnosis. The typical reflux syndrome can be diagnosed on basis of characteristic symptoms without diagnostic testing. Heartburn and regurgitation are the characteristic symptoms of the typical reflux syndrome. About treatment, we have some lifestyle modifications. Weight reduction, cessation of smoking, avoid foods that weaken the lower esophageal sphincter muscle, fat, peppermint chocolate, caffeinated beverages, avoid foods that are irritant to the esophagus, citrus fruits, peppers, and tomatoes. For nighttime GERD, avoid eating at least 3 hours prior to bedtime, elevate the head of the bed, avoid varied decubitus position in bed, turn off lights, and have a nice sleep. Now, PPIs are the main lines of treatment because it is an acid-related disorder. PPIs are considered the most effective medical therapy for GERD due to their profound and consistent acid suppression. However, up to 40% of patients report persistent GERD symptoms despite proton pump inhibitor therapy. Why they are very effective? Because they are the final common path for all the stimuli to the parietal cell, and when the proton pump is blocked, then there will be an effective acid suppression. How can we use PPIs in the treatment of GERD? We start, if there is no alarm symptoms, we'll speak about them later. We start with PPI once daily for 2 months. And then if the patient is not responding, we should check the compliance with the patient. If the patient is not compliant, then if the patient's compliance says okay, we have to move to other PPI or increase the dose twice daily. If the patient is not compliant, then we have ensure compliance. And if the patient takes the PPI twice daily for 2 months and there is a failure, this is the refractory GERD. Refractory GERD is a persistent reflux symptoms despite use of optimum doses of PPIs. It occurs up to 40% of patients treated with a PPI. Now, in the patients with refractory GERD, we proceed for upper endoscopy. If it is normal, then we proceed for pH impedance. If it is abnormal, maybe not acid related, and then we treat as it is. Maybe acid related, either erosive esophagitis or Barrett's esophagus, and then we have intensified medical treatment or think for surgical option. If the patient is refractory and the endoscopy is normal, then we have to do pH impedance. If the patient is not diagnosed before as having GERD, then we do the test of PPI therapy. If there is physiologically AT-AT acid exposure time is physiological and there is no symptom reflux association, and then this patient is not GERD at all. If there is physiological acid exposure with positive symptom reflux, this patient has reflux hypersensitivity. If there is increased esophageal acid exposure, then this patient has GERD, but this is non-erosive GERD because the endoscopy is normal. If the patient has GERD before and is proved, we do pH impedance on PPI therapy to assess this, the efficiency of the PPI. If there is physiological acid exposure and negative symptom association, then this is overlap of GERD with functional disorder. There is physiological acid exposure and the positive symptom association. This is the overlap of GERD with hypersensitivity. If there is increased esophageal acid exposure in spite of the use of PPI, then this patient has refractory GERD. Now we will talk about some pitfalls in the diagnosis and treatment of GERD. First one is overuse of endoscopy in GERD patients. There are certain indications of the use of endoscopy in GERD patients: alarm symptoms, diagnostic problems, heartburn for 5 years or longer, refractory GERD, and preoperative assessment. These are the alarm symptoms: epigastric mass, bleeding, weight loss, vomiting, dysphagia. We shouldn't rush to do endoscopy for a patient with GERD that fulfills the diagnostic criteria symptom-based. The second is assuming an isolated sore throat and pharyngeal pain are related to GERD. Isolated meaning that the patient has no GERD symptoms, but he has some ENT problems. The role of GERD ENT symptoms is difficult to establish. Some laryngoscopic signs such as erythema, vocal cord edema, diffuse laryngeal edema, posterior commissural hypertrophy, granuloma, thick endolaryngeal mucus, and ventricular obliteration can be related to GERD. However, the specificity of these signs for GERD is poor, and some can be encountered up to 70% of asymptomatic subjects. Thus, the presence of ENT symptoms, even when there are endoscopic surgical signs, is not sufficient for the diagnosis of GERD in the absence of other manifestations of GERD like heartburn and regurgitation. Therefore, reflux detection with pH or pH impedance monitoring should be encountered in patients with ENT symptoms to confirm diagnosis of GERD. Thirdly, differentiating between GERD and eosinophilic esophagitis based on response to PPI therapy. The most frequent clinical presentation of eosinophilic esophagitis is dysphagia and food impaction. However, some patients report regurgitation and heartburn. Thus, GERD and eosinophilic esophagitis can have a similar clinical presentation. Eosinophilic esophagitis might also be encountered. Eosinophils might also be encountered in the esophageal mucosa of patients who have GERD. PPI therapy might be effective in patients who have eosinophilic esophagitis in the absence of associated GERD. This feature is called PPI-responsive eosinophilia and might represent a subgroup of eosinophilic esophagitis. Thus, the response to PPI therapy is not a reliable way to differentiate between GERD and eosinophilic esophagitis. Not considering a diagnosis of achalasia in patients who have nocturnal regurgitation. Achalasia is a rare esophageal motility disorder that is characterized by incomplete relaxation of the esophagogastric junction during swallowing and the absence of esophageal peristalsis. Dysphagia and chest pain are the most frequent symptoms of achalasia, but regurgitation can occur as a consequence of poor esophageal clearance. As the symptoms of achalasia can mimic symptoms of GERD, it is recommended that manometry be performed in patients who have GERD symptoms that are resistant to PPI therapy. Not stopping PPI in time prior to certain tests. As we mentioned before, in patients with GERD, suspected to have GERD, who are scheduled for ambulatory pH monitoring, PPI should be stopped 7 days in advance. Testing of a PPI results in a higher diagnostic yield than testing on a PPI. Of course, so the famous example of H. pylori, PPI should be stopped 2 weeks before H. pylori testing to allow H. pylori to repopulate the stomach and increase the chance of positive test. We will talk about H. pylori later. Prescribing a PPI without providing adequate instructions for their use. This is very important. Excretion of acid from parietal cells into the gastric lumen by the pump, the proton pump, is the final step of gastric acid secretion. PPIs accumulate in the secretory canaliculus of the parietal cell, where they are catalyzed to thiophilic sulfonamide, which irreversibly inhibits the proton pump, resulting in a specific and long-lasting impairment of gastric acid secretion. PPIs are thus most effective when concentration of the pump in the parietal cell is highest, which is after a prolonged fast. That's to say before breakfast. So they have to be taken before breakfast. In addition, only activated hydrogen potassium ATPase can be inhibited, and the activation is stimulated by food intake. For these reasons, it is pivotal to instruct patients to take PPI at least 3 minutes before breakfast to ensure that there is an adequate concentration of the drug in the parietal cell before the hydrogen potassium ATPase is activated. This is also the case when there are symptoms predominantly in the evening, as the effect lasts for a long time. So you have to take a PPI in the morning, not in the evening, and it have to be taken on empty stomach because food affects their absorption, and it have to be taken 30 minutes before meals to act on an active proton pump. The next pitfall is increasing PPI dose to treat postprandial heartburn. Early in the postprandial state, an unbuffered acid compartment accumulates below the gastroesophageal junction, whereas the pH in the remaining body of the stomach is still weakly acidic. This pocket is responsible for postprandial heartburn. This can be simply relieved by administration of alginates, not by increasing the PPI dose. They not only function as an acidic neutralizer, but to also create a gel-like substance that flows on top of gastric contents, acts as a barrier to reflux back into the esophagus. Note warning the patient that rebound symptoms can occur after stopping PPI. Rebound hyperacidity occurs after PPI therapy is stopped. The phenomenon is characterized by a temporary increase in gastric acid secretion above pre-treatment levels and is attributable to the hypergastrinemia that occurs during PPI treatment. The effect is most obvious in patients who have used PPI for at least 2 months, and a related increase of symptoms is often observed within 2 weeks of PPI treatment being withdrawn. In this case, you can use some H2 receptor blockers and reassure the patient. And we can use also antacids. Stopping a PPI because of funding gland polyposis. Funding gland polyps are the most frequently found gastric polyps, being diagnosed in about 2% of general population. The risk of developing funding gland polyps increases fourfold in patients receiving long-term PPI treatment for at least 1 year. The mechanism is not entirely clear. One hypothesis is that mucus blocks the funding glands, and as a result of decreased flow of glandular secretions, the blocked funding glands may form cysts and eventually funding gland polyps. Funding gland polyps associated with PPI use have a negligible risk of malignant progression and rarely show dysplasia. Routine surveillance is therefore not recommended, nor is stopping the PPI if there is good indication for it. Withholding PPI treatment because of fear of complications. Several studies, mainly controversial, have raised concerns about the safety of PPI use, mostly regarding increases of osteoporosis, pneumonia, and enteric infections. No dose-response or temporal relationship between PPI use and its alleged complications have been described. Moreover, the associations described are mostly weak. If there is a good indication the benefits of PPI treatment outweigh the potential risks, then patients should not have an effective treatment without. Weight-reducing surgery relieves GERD symptoms. Of course, obesity is one of the precipitating factors for GERD. So if we have a weight-reducing surgery, then it is supposed that GERD will improve. But this is not the case in all cases of operations, of bariatric operations. Sleeve gastrectomy can promote less GERD by reversal of the weight and visceral adiposity. There is also the potential for increased gastric emptying, thereby decreasing stomach pressure and reducing GERD. Furthermore, as a large part of the fundus is resected during sleeve gastrectomy, this results in removal of the majority of the parietal cells of the stomach, and so gastric acidity will decrease. So it is supposed that this will improve GERD symptoms. But there is a observation that there is increasing GERD or even the development of new onset GERD after sleeve gastrectomy. There are some explanations. Alteration of the angle of His, which normally acts as a valve to prevent a reflux of stomach contents into esophagus. Lower esophageal sphincter dysfunction can also occur after a sleeve gastrectomy with resection with transection near the angle of His during gastrectomy. The sling fibers at the fundus are divided, which can subsequently decrease lower esophageal sphincter pressure. A further anatomical change observed after a sleeve gastrectomy is hiatal herniation. Sometimes the part of the sleeve goes above the diaphragm. As the majority of the fundus is excised in sleeve gastrectomy, there are decreased levels of garline, after sleeve gastrectomy. This may explain the slowed gastric emptying seen 1 year after the procedure. Testing and treating H. pylori in GERD patients. Actually, this point is controversial. The role of H. pylori infection in GERD is controversial since its associated gastritis can lead both to an increase or to a reduction of acidic secretion, depending on the affected gastric region. On one hand, H. pylori associated antral gastritis causes hyperacidity, aggravating GERD. Corpus gastritis results in hypoacidity and plays a protective role against the disease. The majority of cases of H. pylori infection are, of course, corpus gastritis and not antral gastritis, and so it's supposed that they are protective against GERD. H. pylori had improved esophageal peristalsis, enhanced lower esophageal sphincter pressure, and reduced esophageal acid exposure, indicating a protective effect on esophageal mucosa from H. pylori. Also, the infection can stimulate the vagus nerve receptor on the fundus and the card of the stomach and increase serum gastrin secretion, which can enhance lower esophageal sphincter pressure as well as reduce gastric acid reflux, thereby protecting esophageal mucosa. H. pylori eradication does not influence GERD symptoms. It has no effect on GERD symptoms, so it should not be used. So H. pylori treatment should not be used as a treatment of this disease. H. pylori infection may reduce the risk of development of esophageal adenocarcinoma. This point actually is controversial, but the test and the treat strategy of H. pylori cannot be applied in cases of GERD. Routine screening of GERD patients for Barrett's esophagus. Of course, not all patients should be screened for Barrett's esophagus. This is the American College of Gastroenterology guidelines. Screening for Barrett's esophagus may be considered in men with chronic, more than 5 years, and or frequent symptoms of GERD, and 2 or more risk factors for Barrett's esophagus. Given the substantially lower risk of adenocarcinoma in females with chronic GERD symptoms, when compared to male, screening for Barrett's esophagus in females is not recommended. And here are the risk factors for development Barrett's esophagus. If there are 2 of these in males, then the screening might be justified. Chronic, more than 5 years GERD symptoms, advancing age, male gender, tobacco usage, central obesity, and Caucasian race. The last one is intensified treatment in cases of Barrett's esophagus. Here are the AGA guidelines. Patients with Barrett's esophagus should receive once daily PPI therapy. There is no need for intensification of treatment, but they are treated as the usual guidelines for GERD without Barrett's esophagus. Routine use of twice daily doses is not recommended unless necessitated because of poor control of RAC symptoms or esophagitis. However, the AGA recommends the long-term use of PPIs in case of Barrett's esophagus because they claim that it will reduce the incidence of dysplasia and adenocarcinoma. Anti-reflux surgery should not be pursued in patients with Barrett's esophagus as an antineoplastic measure. However, the surgery should be considered in those with incomplete control of reflux on optimized medical therapy. The same indication as in patients with GERD without Barrett's esophagus. And finally, stay safe. This is this was put in one of the famous malls in America. Avoid touching men, instead follow women. Actually, it is nice, and I will conclude by this my presentation. And thank you.
Thank you,